welcome all for the today's session. So today we continue with our endocrinology module, and today's topic for the discussion is the adrenal cortical hormones. This is very important from the examination point of view, and at least 2 to 3 SBAs you will have from this particular session. So please listen to this talk very carefully. We know from our basic knowledge of MBBS that adrenal gland has got two parts, the medulla and the cortex, and these are the two functional parts which behave in a different way because medullary hormones are different and the cortical hormones are different. And what we are going to discuss now is the cortical hormones. Okay, so this adrenal cortex has got three parts. Okay, this is called a zonation of the adrenal cortex, and this is the SBA which they are asking you. Particular hormone comes from which zone? Okay, so hormone and the zone, that is the SBA which is more frequently asked. So you have zona glomerulosa, which will secrete mineralocorticoid, that is aldosterone. Then you have zona fasciculata, which will secrete the glucocorticoids, that is the cortisol mainly, and other is a cortisone. And third is a zona fasciculata, which will secrete the androgens, then testosterone, estrogen, etc. Okay, so in short, just remember the short form. From outer to inner side, you have glomerulosa, followed by fasciculata, followed by reticularis. Okay, so outer layer is a glomerulosa, middle layer is a fasciculata, and inner layer is a zona reticularis. Okay, remember GFR. Okay, short form. From outside to inside, it is a GFR. Okay, and all three hormones you remember for this, and for this also SSS. Okay, salt, steroid or sugar, and third is the sex hormones. Okay, so salt is aldosterone, sugar or the steroid, because it has got a action on the metabolism, it increases the glucose level. Okay, so is coming from F region, that is the fasciculata, and the last one is the sex hormone, that is the testosterone, estrogen will come from reticularis. Okay, so GFR, SSS. So S for sugar, yes, S for salt first, then comes the sugar or the steroids, and third is the sex hormone. Okay, so that is the way you remember. Okay, so you have zona glomerulosa. It is a mineralocorticoid hormone. It has got a 21 carbon compound. It's a 21 carbon. Okay, so please remember this carbon, number of carbon atoms also. It is a main hormone is a aldosterone, and the function is mainly the sodium retention and the potassium excretion. Second, the middle layer is zona fasciculata. It secretes the glucocorticoids. Again, this is a C21 carbon. It has got a 21 carbons, and major hormone is a cortisol. Okay, and it has got action on the glucose metabolism and in the stress. Third is a zona reticularis, which secretes the androgen and the estrogen, and this androgen are the C19 molecule, while the estrogen is a C18 molecule. Okay, the main action, main hormone is a DHEA and androstenedione. So remember, from adrenal cortex, what you get a DHEA and the androstenedione. When we talk about androgens, androgens are the testosterone also, but here uh, in adrenal cortex you will get mainly the DHEA and the androstenedione, and the action is on the secondary sexual characteristics development. Okay, so mnemonic is a GFR, from outside to inside, and it is a salt, sugar, and sex. Sugar is equal to steroids also, you remember. Okay, from outside to inside, if you are asked about the source of mineralocorticoid, it will be glomerulosa. If you are asked about the steroids, it will be the fasciculata. If you are asked about the sex hormones, then it will be the reticularis. Okay, so this is the way you remember. Then coming to the synthesis of the steroid hormone, the basic molecule which is required for the synthesis of this hormone is the cholesterol. Okay, from cholesterol you are getting these hormones. So cholesterol is converted into pregnenolone, and the enzyme responsible is the desmolase enzyme. It is a side chain cleavage enzyme. That is the rate limiting step, and it is stimulated by ACTH. Please remember this, cholesterol to pregnenolone is, this is the rate limiting step. Enzyme involved is a desmolase. It cleaves the side chain. Okay, so it's a side chain cleaving enzyme, and it is stimulated by ACTH. This is the rate limiting enzyme. Okay, and for all these steroid hormones, the basic raw material is the cholesterol. Okay, so we go ahead. So the pregnenolone is, is the mother progesterone, you can say, which is involved in creation of all these steroid hormones. So further, this pregnenolone is converted into progesterone. Okay. So enzyme involved is a 3-beta hydroxysteroid dehydrogenase. And here they convert delta 5 into delta 4 conversion. This 3-beta hydroxysteroid dehydrogenase. So double bond at 5 will be converted into double bond at 4. Okay. So pregnenolone will be converted into progesterone. Okay. The rate limiting step we have already seen. Okay. Now this progesterone will further form the glucocorticoids, mineralocorticoids, and sex steroids. So these are the final products. So all mother is this progesterone. Okay, this progesterone, the basic is a pregnenolone, and this pregnenolone, the raw material is a cholesterol. This is what you should remember. Okay. Now same thing is described here in this particular figure. That what you see here, these are the precursors. The cholesterol is converted into pregnenolone, pregnenolone is converted into progesterone. So the precursors are here. Then the second column, the second here row, what you see is the intermediate products. Okay, 17-hydroxy pregnenolone, 70-hydroxy progesterone, androstenedione. So these are the intermediate products. And further here, if you go down, here you see the main hormones which are produced. That is the cortisol, which is 21 carbon molecule. Then dehydroepiandrosterone, DHEA is produced. Then you get a testosterone, which is a 19 carbon compound. Then this is estradiol, which is a C18. It has got a 18 carbon molecule. Then corticosterone, and here it is a aldosterone, which is also 21 carbon molecule. And these are the metabolites, final metabolites which are excreted. You have 17-hydroxysteroid, which is excreted in the urine. Then you have DHEAS, that is DHEA sulfates, and that is also converted into 17-hydroxysteroid in the urine. Okay, so this is what is the summary of the pathway what we have discussed. That is the major pathways for production of the glucocorticoids and mineralocorticoids and the sex steroids. Precursors what we have seen in the red box, that is the cholesterol to pregnenolone to progesterone. Then we had the intermediate products in the gray box and the hormones in the blue box main. Okay, so cortisol, DHEA, testosterone, aldosterone, these are the main hormones, while the excretory products are the 17-hydroxysteroids in the urine, DHEA sulfate, and 17-hydroxysteroids. So these are the metabolites. Now the key concept here is all steroid hormones are derived from the pregnenolone. Reactions involve mainly the hydroxylation, and enzymes are the monooxygenase, which require NADPH. Okay. Now let's talk about the important hormone. We'll discuss about the glucocorticoids, mineralocorticoids, and the androgens. Okay, which are the hormones of the adrenal cortex. Now, this glucocorticoid main hormone is a cortisol, and to some extent there will be cortisol and corticosterone. So these will be minor ones. The main is a cortisol. In the mineralocorticoid, you have mainly aldosterone. Then another will be deoxycortisone. This is lesser amount. Then you have androgens, and main androgen is DHEA. Okay, and second is an androstenedione. So these are the adrenal androgens. Once we talk about adrenal androgens, think of DHEA and androstenedione. Okay, because sources of androgen is also from ovary, okay, or the gonads. So those hormones will be the mainly there will be testosterone. No doubt these will also be converted into testosterone, but the predominant hormones are the DHEAs and the androstenedione. Now, how is the regulation of this secretion of the hormones? It is mainly controlled by the ACTH. We know ACTH is coming from the pituitary and acting on this adrenal cortex and will stimulate the secretion of these hormones. This has got a diurnal rhythm. The peak is in the early morning and the lowest is in the midnight. So, and how this ACTH is controlled? ACTH has got a control from hypothalamus in form of CRH. That is the corticotropin releasing hormone that will stimulate the ACTH, and the ACTH will act on the adrenal cortex and it will secrete the cortisol. There is a negative feedback. So these cortisol which is secreted will inhibit at the pituitary level, will reduce the ACTH. It will also cause inhibition at the hypothalamic level and it will reduce the CRH. That is the long loop mechanism. Okay. Now coming to the regulation of the aldosterone. So adrenocortical hormones are mainly under the control of ACTH. However, there is one thing which you have to remember, especially with the aldosterone. Okay, so this they can ask you this concept, aldosterone regulation. ACTH has got a minor role here. Okay, because aldosterone is also influenced by the posture. In upright posture, it increases, and in supine position, it decreases. Why? Because here, instead of ACTH, ACTH has got a minor role, but the major role or the major control of aldosterone regulation is through RAAS, renin-angiotensin aldosterone system. That mainly regulates this aldosterone. Okay, ACTH minor role as far as aldosterone is concerned. So standing activates renin-angiotensin aldosterone system slightly due to reduced effective renal perfusion, and therefore aldosterone rises in the upright position. Okay, so aldosterone secretion is mainly controlled by the angiotensin 2 and serum potassium level, while ACTH has got only a minor permissive role. Okay, so please remember this concept if they can, because if both options are there, you will select the RAS, or you may select angiotensin 2. Okay, or it may be potassium. Okay, so while ACTH has got a minor role. Then coming to the transport and metabolism. So mainly the hormone is a 70% bound to the proteins in form of CBG, corticotropin binding protein, also called as transcortin. 20% is bound to albumin and 10% is in the free form, and it is the free form which is mainly active. So only free cortisol is biologically active. Half-life is 2 hours only. These hormones are metabolized in the liver, and the processes involved are the reduction and the conjugation. So final products which are excreted are the glucuronides and the sulfates. They are excreted in the urine. So these are the steroid hormones which are metabolized in the liver and excreted through the kidney in form of glucuronides and the sulfates. Okay. Now the urinary steroids. Okay. So when they are excreted in two forms. One is a 17 ketosteroids and second one is a 17 hydroxysteroids. So these products are excreted in the urine in form of 17 ketosteroids. And these 70 ketosteroids, they are the products from the adrenal plus gonadal. Mainly these are the androgens. Okay, so these 17 ketosteroids, the source is from adrenal plus gonadal, and the test for detection of these 17 hydroxysteroids is a Zimmermann reaction. Okay, so it gives the purple color. When these 17 ketosteroids are present, the Zimmermann reaction will give the purple color, and the source of these ketosteroids is from the adrenal as well as gonadal. While 17 hydroxysteroids is mainly from the adrenal. Okay, and the test here is a Porter-Silber reaction. Okay, so second test is a Porter-Silber reaction, and it will detect the 17 hydroxysteroids, and this is mainly from the adrenal only. So source of this is mainly the adrenal. Okay, these reactions are older reactions. I don't think they will ask you, because nowadays enzyme assays are mainly carried out and not these traditional tests. Okay, so another thing what you should remember is a 11 oxygenation index. That is when 11 oxygenation is present, it denotes the particular molecule is from the adrenal origin. And these 17 ketogenic steroids, which are the metabolites, they include both keto as well as hydroxy at carbon 17. So these androgens, which are from the adrenal as well as gonadal, they will give products as a 17 ketosteroids. Now these 17 ketosteroids, they include both keto plus hydroxy at C17, carbon item 17. So even if a steroid starts at hydroxy at C17, the body can convert it into keto form. So both are grouped together as 17 ketogenic steroids. So these are the ketogenic steroids. It doesn't mean that they have the ketone group as such. They have the ketone groups, or it may be a hydroxyl group, but the body can convert it into ketone group. That is why they are called as ketogenic steroids. Okay, so 11 oxygenation is adrenal origin marker, and 17 ketogenic group that includes both 17 ketosteroids as well as 17 hydroxysteroids. This much detail they may not ask you, because these are the older things. Okay, may not be expected from your level. Okay, so Zimmerman is a 17 ketosteroids. It gives a purple color, while Porter Silver is for detects 17 hydroxysteroids. These are the cortisol metabolites. Okay, so these older biochemical tests were historically important in diagnosing adrenal disorders before modern hormone assays became available. So for adrenal hormones, whichever the test which are carried out clinically, we will discuss at the end of this session. Okay. So important reaction, the older ones were the Zimmerman reaction. It gives the purple color with metadinitrobenzene, and another is a Porter Silver reaction for 17 hydroxysteroids. Okay. Now coming to the biological effects of glucocorticoids. What is the effect of glucocorticoids? Basically, on the metabolism, it will increase the gluconeogenesis. On protein, it will break down the protein. Then fat, it will cause the redistribution of the fat, leading to the central obesity. On immune system, it will cause immunosuppression. On cardiovascular system, it will maintain the blood pressure. And on the bone, it will cause the osteoporosis. Okay. Now, assessment of glucocorticoid secretion. Okay. Now, plasma cortisol. It is high in the morning around 9 a.m. You will have the levels of 5 to 25 microgram per deciliter. At 10 p.m. 2 to 5 microgram per deciliter, because this is stress hormone. So daytime the requirement will be quite high, so the body will have high levels early in the morning by 9 a.m. and by 10 p.m. When the parasympathetics are acting, there is no much activity, the level will be the lowest. So the loss of diurnal rhythm is suggestive of early disease. Okay, so that you should remember. If this diurnal rhythm is disturbed, that is an indication of the disease. Then urinary free cortisol. This urinary free cortisol reflects biologically active cortisol. So it is increased if there is a hypercortisolism, and it is decreased if there is an adrenal insufficiency. Now, plasma ACTH level. Now, what will happen to the plasma ACTH level? If there is a primary hyperadrenalism, the ACTH levels will be reduced, because higher cortisol level will cause suppression at pituitary level. So plasma ACTH levels will be reduced. That is suggestive of primary hyperadrenalism. Second, the Cushing's disease. The Cushing's disease is pituitary adeno. The pituitary has fault. So there will be increase in the ACTH levels. Okay. Third, ectopic ACTH. In ectopic ACTH levels, there will be tremendous levels of ACTH. Okay. And if there is adrenal insufficiency, again, the ACTH levels will be increased. So in primary hyperadrenalism, ACTH levels will be reduced, while in adrenal insufficiency, the ACTH levels will be increased. Okay. Now coming to the various tests. Okay, these tests, last time also few tests we have discussed. First is a dexamethasone suppression test. Okay, now what does this dexamethasone? We are giving the steroids from the outside. So these steroids will act and inhibit at pituitary level. They will reduce the ACTH level, and hence the cortisol level will be reduced. Okay, so you have low dose DEXA suppression test, you have a high dose DEXA suppression test. Last time we have discussed this along with the ACTH. Okay, so basically this DEXA suppression test will lead to the decrease in ACTH levels and will reduce the cortisol. That is the normal response. However, in Cushing's, okay, if it is there is a pituitary edema, there is no suppression. Okay, so this is what you have to remember. Okay, next is a ACTH stimulation test, also called as Synacthen test. Okay, ACTH stimulation test or the Synacthen test. So normal response, when you give ACTH, what is going to happen? It will increase, it will act on the adrenal, and it will increase the cortisol level. So if the adrenals are failing, there will be no response. Okay, so when you give ACTH, normally you should expect the adrenal should increase cortisol. If this is not happening, that means there is an adrenal failure. So primarily when we talk about ACTH stimulation test, it is the adrenal glands ability to produce the cortisol. That is what we are testing. Okay, so ACTH stimulation test, we are primarily detecting adrenal glands ability to produce cortisol. So when to use? When we suspect the Addison's disease or the adrenal failure, clinically presenting as a fatigue, hypotension, hyponatremia. To confirm the adrenal insufficiency, we carry out this ACTH test. It checks the adrenal factory, whether this factory is working well or not. It differentiates adrenal cause, that is the primary, whether the primary adrenal is at fault, or pituitary, which is the secondary adrenal failure. So in secondary, that is the pituitary cause, the response will be blunted or delayed response. Okay, because in that particular case, for a long time the adrenals are suppressed. So when you give the ACTH or the Synacthen, what the response will be, it will be delayed response or it will be blunted response. But if it is a primary adrenal which is at fault, there will be no response at all. Okay, so the blunted response because adrenal is understimulated for a longer time. So if it is a secondary cause, it will be blunted or the delayed response. Next test is a Metyrapone test. Okay, so what does this Metyrapone test do? Metyrapone test will detect the integrity of the hypothalamo-pituitary adrenal axis. So this HPA axis integrity is checked by the Metyrapone test. So to assess this uh, pituitary ACTH reserve, okay, when to do? When we suspect the secondary adrenal insufficiency or the pituitary dysfunction. So if we are suspecting the pituitary are at fault, we will do this Metyrapone test. So what does this Metyrapone do? This Metyrapone blocks the cortisol synthesis by blocking certain enzyme. So it increases the ACTH. There is an increase in the 17 ketosteroids because the cortisol synthesis is blocked. Okay, so normal response after giving this Metyrapone is there is a decrease in cortisol level and increase in ACTH levels and increase 17 ketosteroids. That indicates the intact HPA axis. Okay, so Metyrapone blocks the cortisol. Okay, so basically it causes inhibition of the 11 beta hydroxylase enzyme. Okay, so normal response is a decreased cortisol, increase ACTH levels and increase 17 ketosteroids. So that indicates the HPA axis is intact. But if there is an abnormal response, such as no rise in ACTH or metabolites, the problem is at the level of the pituitary because there is a decreased ACTH or because of that, the adrenals will not respond. Okay, so the pituitary is at fault. So this is what is the interpretation. So Metyrapone inhibits 11 beta hydroxylase, decreases cortisol and thereby stimulates the compensatory ACTH secretion. So let us see about the Synacthen test, that is the ACTH test and the Metyrapone test. So in ACTH or the Synacthen test, what basically it tests? It tests the adrenal response after giving the ACTH, and it is mainly the primary adrenal failure which is detected by ACTH test. Okay, then Metyrapone test, it will detect the pituitary plus HPA axis and mainly the secondary causes this Metyrapone will detect. Third test is a CRH test. Now this CRH will differentiate whether it is a primary, secondary or the tertiary cause. Primary cause means at the level of the adrenal, secondary at the level of the pituitary, and third at the level of the hypothalamus. Okay, so when you give CRH, so what should happen? It will stimulate the pituitary to secrete the ACTH, and ACTH will further act on the adrenal and will increase the cortisol. So now this is what is the normal response. So if it is a primary adrenal failure, what will happen? The defect is in the adrenal. So after giving CRH, the ACTH will be increased, but the cortisol will not increase. Okay, so this is what is the primary adrenal failure after administration of the CRH. So CRH will stimulate the pituitary. So ACTH will increase, but the primary adrenals are at fault, so cortisol will not increase. Now coming to the secondary, that means the pituitary at fault. So if you give the CRH, there will be no increase in the ACTH, or there may be very low rise of the ACTH and there is no rise of the cortisol. Now, if the hypothalamus is at fault and you give artificially CRH, what will happen? ACTH will increase, but there will be delayed rise because it is a chronically inhibited pituitary. Okay, so there will be delayed rise and also cortisol will also show delayed rise. That means the hypothalamus is at fault. Okay, so now we will go for adrenal hyperfunction and the adrenal hypofunction. Okay, now adrenal hyperfunction. So when it is a primarily adrenal hyperfunction, we call it as a Cushing syndrome. When it is a secondary, because of the pituitary edema, we call it as a Cushing disease. Okay, And third is the ectopic secretion of ACTH. It may be any tumor which is producing ACTH. That all will lead to the adrenal hyperfunction. So if it is a primary adrenal hyperfunction, it is called as Cushing syndrome. If it is a secondary, then it is called as secondary to pituitary adenoma, it is called as Cushing disease. And sometimes there can be ectopic secretion of the ACTH from the tumor. Okay. Now the adrenogenital syndrome. What are the findings? So adrenal hyperfunction may be because of the adrenal adenoma, maybe because of the adrenal carcinoma, it may be because of pituitary adenoma, or it may be ectopic ACTH secretion. Okay. So this is the adrenogenital syndrome, in which there can be problem at the level of the adrenal, which may be adrenal adenoma or adrenal carcinoma. It may be pituitary adenoma, or there can be ectopic ACTH secretion. All this will have the hyperfunction of the adrenals. So what will happen to the plasma cortisol? So it will be increased and the diurnal rhythm will be lost. In adrenal adenoma also, then adrenal carcinoma, again plasma cortisol will be decreased, the diurnal rhythm will be lost. Pituitary adenoma will also have the higher cortisol levels, and there is no diurnal rhythm. In ectopic ACTH production also, the cortisol level will be high and there will be no diurnal rhythm. Okay. Now, what happens to the urinary cortisol? If it is an adrenal adenoma, the free cortisol level will be increased. In all four conditions, you will have the increased free cortisol. Okay. So, but what happens to the plasma ACTH? Now, because the adrenals are fault, they are secreting excess of cortisol. This excess of cortisol will act on the ACTH, on the pituitary, and will reduce the plasma ACTH. So, if it is an adrenal adenoma or adrenal carcinoma, ACTH levels will be reduced. But if it's a pituitary adenoma, which is secreting large amount of ACTH, the ACTH levels will be high. And if it is an ectopic production of the ACTH, then also the ACTH levels, plasma ACTH levels will be increased. So this is how you are going to differentiate adrenal cause from the pituitary cause. Okay. Now, when you carry out the Dexa suppression test, what is the response? When you give the dexamethasone, there is no suppression with the low dose if it is a pituitary, if it is an adrenal adenoma. If it is an adrenal carcinoma, there is no suppression even with a higher dose. Okay. If it is an adrenal carcinoma, there is no suppression. So when you give dexamethasone at lower dose, there is no suppression of the cortisol. But it will at higher dose, it will suppress. But if it is an adrenal carcinoma, even at higher dose, there will be no suppression. Now, what will be response in cases of pituitary adenoma? There will be suppression with high dose. Okay. Pituitary adenoma will be suppressed, cortisol will be suppressed at a higher dose. Okay. Then ectopic ACTH production, there is no suppression. That is what is the role of the dexamethasone suppression test. So the dexamethasone suppression test, the first is to detect whether it is adrenal is fault, or what is that fault. Second is to locate. Okay, you carry out the higher dose dexamethasone suppression test. So in adrenogenital syndrome, okay, so most of the time the presentation may be in form of hirsutism. Okay, and there will be clinical question on the hirsutism, and this topic is very frequently asked. Okay, so when the patient is presenting with hirsutism, how to evaluate, and they will give the lab scenario also, lab parameters also, how to answer this particular question. Please concentrate on this. Okay, so in adrenogenital syndrome, what happens? 17 hydroxy progesterone levels are high. So adrenal hyperplasia, the 17 hydroxy progesterone is the marker. Testosterone level will be increased, DHEA levels will be increased. However, LH and FSH levels may be, LH levels may be normal or increased, FSH levels may be normal or reduced also. Then if it is a simple hirsutism, 17 hydroxyprogesterone level is normal, testosterone is slightly increased, DHEAS is slightly increased, FSH and LH levels are normal. So if it is just a simple hirsutism where there is a mild androgen levels are high, then these levels will be mildly more than the normal, while here it will be more than the lab values in a quite high percentage. Okay. Now, if it is adrenal tumor, okay, if it is an adrenal tumor, then 17 progesterone, 17 hydroxyprogesterone will be normal. Testosterone will be slightly normal, but DHEAS will be increased. We have seen androgen has got two sources, adrenal as well as ovarian. When it is adrenal, DHEA levels will be high. When it is ovarian, testosterone levels will be high. And all this will present as a hirsutism. Okay. So adrenal tumor, DHEA levels will be increased. Ovarian, testosterone levels will be increased. Okay. And FSH and LH levels in adrenal tumor may be normal or may be reduced. In ovarian tumor, it may be normal, it may be reduced. Okay. So look at what is increased. If it is a 17 hydroxyprogesterone increase, we are dealing with adrenogenital syndrome. Okay, so if it is adrenogenital syndrome, 17 hydroxyprogesterone levels. If it is an adrenal tumor, DHEA levels will be high. If it is a ovarian tumors, you will have testosterone. And for simple hirsutism, only testosterone mild increase, DHEAS mild increase, rest of all the hormones are normal. So I hope you have understood this because generally the questions are asked on this. So markedly elevated 17 hydroxyprogesterone is the hallmark of congenital adrenal hyperplasia. This remember, please remember this sentence. Markedly elevated 17 hydroxyprogesterone is the marker of congenital adrenal hyperplasia. DHEAS mainly produced by the adrenal gland. In hirsutism or virilisation questions, you will only need to answer two things. One, where is the androgen coming from? Whether it is coming from adrenal or whether it is coming from ovary. Is it pathological or is it mild? So these are the questions which we need to answer when if we have got any question on hirsutism. And most of the time hirsutism there is only one question. Okay. So DHEAS is the adrenal marker produced only by the adrenal. So high DHEAS adrenal problem until proved otherwise. Okay. Now coming to the testosterone, it is the ovarian marker, mainly ovarian, because even if it is a androstenedione and DHEAS increase, they will also get converted to the testosterone peripherally, but the amount is less. Okay, so here markedly increased testosterone is a ovarian marker. It can be from ovary also, it may be from adrenal also. Okay, but very high testosterone, think of ovarian tumor. Now 17 hydroxyprogesterone we have already seen, it is a CAH marker, congenital adrenal hyperplasia. It is elevated in congenital adrenal hyperplasia or adrenogenital syndrome. 70 hydroxyprogesterone is a screening test for congenital adrenal hyperplasia. Okay. Now coming to the adrenal hypofunction, also called as Addison's disease. Okay. So key features are the presentation is with fatigue, dehydration, hyponatremia, and hyperpigmentation because ACTH levels are high and that will produce the MSH effect. Okay, melanocyte stimulating hormone effect will be there and there will be hyperpigmentation. So if you see hyponatremia with hyperpigmentation, think of Addison's disease. Okay, so adrenal hypofunction, it may be primary, secondary, or the tertiary. What happens if it is a primary adrenal function? The cortisol level will be reduced, but the ACTH levels will be increased. On CRH test, there will be no response. This is what we have seen the CRH test. Okay, and there will be hyponatremia and potassium levels will be high. This is the primary Addison's disease, primarily adrenal hyperfunction. If it is because of the pituitary, the cortisol will be reduced. ACTH will also be reduced. But if you do the CRH test, there will be normal response because CRH, after CRH, the response will be normal. The sodium will be reduced. The potassium will also increase. While if it is a tertiary, that if it is a hypothalamus is at fault, the cortisol level will also be low. ACTH levels will also be low, and there will be exaggerated response of the CRH. Okay, and sodium will be reduced and the potassium will be increased. Okay, so take home message is that rate limiting step is the cholesterol to pregnenolone, and the enzyme responsible is a desmolase. Then most active cortisol fraction is the free cortisol. Best screening test is the urinary free cortisol. Diurnal rhythm lost in early disease. Hyperpigmentation is because of the high ACTH levels, and no suppression in the dexamethasone test is suggestive of the Cushing. Okay, so that finishes the today's topic of adrenal cortical hormones.
Question one, rate limiting step in steroid hormone synthesis is A. Conversion of progesterone to cortisol, B. Cholesterol to pregnenolone, C. Pregnenolone to progesterone, D. Cortisol to cortisol to cortisone, and E. Aldosterone synthesis. So answer is B. Cholesterol to pregnenolone.
Yes, pregnenolone is the important step or the rate limiting. Next.
Question two, which enzyme is responsible for rate limiting state in steroid synthesis? A. Aromatase, B. 21 hydroxylase, C. Desmolase, D. 5 alpha reductase, E. 11 beta hydroxylase. So answer is C. Desmolase.
Desmolase. Okay, so now we have just finished the session, but when you have all the rate limiting enzymes from the Krebs cycle, these that, you will get confused. Okay, so when you study now, please take down your own notes. Okay, next.
Question three, which adrenal zone produces glucocorticoid? A. Zona glomerulosa, B. Zona reticularis, C. Zona fasciculata, D. Medulla, E. capsule. Sir, answer is Zona fasciculata. C.
Correct. Okay, so this is very frequently asked question. Next.
Question four, the biological active fraction of cortisol is A. Albumin bound, C. B. CBG bound, C. Free steroid, D. Conjugated cortisol, E. Sulfated cortisol. The answer is B. CBG bound.
No, biological active will be the free cortisol.
Free cortisol.
Free cortisol will always be the active. Okay, but
Yes, sir.
maximum you will get with CBG bound 70%. 20% is the
Okay.
albumin bound. Remaining will be the free cortisol, and the free cortisol is the active form. You got it? Okay. Next.
Yes, sir. Yes, sir. So question five, loss of diurnal variation in cortisol is early feature of A. Addison disease, B. Cushing syndrome, C. Crohn's syndrome, D. SIADH, and E. Diabetes mellitus. Sir, is it Cushing or Addison?
It will be Cushing's. Okay.
Cushing. Addison, तो there will not be
It
a
will be hypofunction.
cortisol.
Okay.
हाँ, Question
Next.
six, the best screening test for Cushing syndrome is A. Plasma ACTH, B. Serum cortisol, C. Urinary free cortisol, D. CRH test, and E. Metyrapone test. So, answer C. Urinary cortisol, free cortisol.
Cushing syndrome, urinary free cortisol. Next.
Question seven, in primary adrenal insufficiency, ACTH level can be decreased, D increase, D absent, and E variable.
Primary
Sir,
adrenal insufficiency.
ACTH will be increased.
Correct. Correct. Dr. Sansi, will you answer next questions?
Yes, sir. Dexamethasone suppression test in Cushing syndromes typically shows in Cushing syndrome increased suppression, normal suppression, no suppression, increased ACTH only, decreased ACTH only. No dexamethasone suppression test in Cushing syndrome. So no suppression at
Yes,
low dose.
there is no suppression in the Cushing syndrome. Okay. Next.
Which features characteristics of Conn syndrome. Hyperkalemia, hyponatremia, hypokalemia, acidosis, and or low aldosterone. Conn syndrome, hypokalemia, sir.
Cons, what happens? Hypokalemia. Cons is a
Opposite of additions.
yeah.
Most common enzyme deficiency in congenital adrenal hyperplasia is 17 hydroxylase, sir.
Is it congenital adrenal hyperplasia? 17 hydroxylase. So it is 21 hydroxylase. 21 hydroxylase, not 17 hydroxylase.
Which test evaluates adrenal reserve? Dexamethasone test, CRH test, ACTH stimulation test, Metyrapone test, urinary cortisol.
Adrenal
reserve.
reserve.
So dexamethasone test, sir. Option A.
Adrenal reserve. ACTH stimulation test, because ACTH will be directly acting on the adrenal and will stimulate. So reserve will be tested by the ACTH stimulation test. Next.
Okay. Hyperpigmentation in Addison's disease is due to increased MSH level, that is due to increased aldosterone level. No. Increased hyperpigmentation in Addison's disease is due to increased aldosterone level. Option B, sir.
No, it is increased ACTH level, which will have the effect which is similar to MSH. No. Okay. So
Sir, excuse me, sir. So
yes, yes.
Addison disease is a adrenal insufficiency. Okay, sir.
Hi.
Adrenal
There
insufficiency.
will be
Yes.
increased ACTH.
So adrenal insufficiency will have the higher levels of ACTH,
ACTH.
right? So there will
Yes.
be MSH
Yes.
effect. Okay. Yes, doctor, go ahead.
A 22-year-old woman presents with rapid onset hirsutism and deepening of voice over 3 months. Investigation shows progesterone level as normal, testosterone normal, DHEAS markedly elevated, LH and FSH is low. What is the most likely diagnosis? Sir, option C, adrenal tumor.
By adrenal tumor,
DHEAS is specific marker of
yes,
adrenal.
markedly elevated. Okay, so it is an adrenal tumor. Okay, marked increased DHEAS is the adrenal source, testosterone not very high, not ovarian tumor, rapid virilization, that is suggestive of tumor, not the simple hirsutism. Okay, so key rule, DHEAS tremendously increased, think of adrenal tumor. Next.
A 19-year-old girl presents with hirsutism since adolescence. Investigations show 17-hydroxyprogesterone markedly elevated, testosterone elevated, and DHEAS elevated. What is the most likely diagnosis? Ovarian, simple hirsutism, ovarian tumor, adrenal tumor, congenital adrenal hyperplasia, hyperprolactinemia. All of them are increased. Sir, congenital adrenal hyperplasia. Option D.
Yeah, because there is a marked elevation in the 17
Hmm.
hydroxyprogesterone. Okay, that is the diagnostic clue. Both adrenal and androgen pathways will be active. So classic of for congenital adrenal hyperplasia. Next.
A 30-year-old woman presents with gradual hirsutism. Progesterone levels are normal. Testosterone is slightly higher. DHEAS is slightly higher. LH and FSH is normal. CAH, option, what is the most likely diagnosis? CAH, adrenal tumor, ovarian tumor, simple hirsutism, Cushing syndrome. The adrenal tumor, DH, but it is slightly higher than simple hirsutism.
Yes, it is simple
Option D.
hirsutism. Okay,
Hmm.
because both are mildly raised. Testosterone and DHEAS, they are mildly raised. It may be because sometimes the free hormone levels are also increased for some reason. Okay, the total level may be normal, but whatever the increase is there, that will also produce the effect. You got it. So only mild hormonal, simple hirsutism, only mild hormonal changes. So no marked elevation of any marker. So we will think about benign or the simple hirsutism. Next, doctor, continue.
A 35-year-old woman presents with rapid virilization. Investigation suggests 17-hydroxyprogesterone is normal. Testosterone is markedly elevated. DHEAS is normal. LH and FSH is low. CAH, adrenal tumor, ovarian tumor, PCOS, simple hirsutism. Sir, ovarian tumor, option
Yes,
C.
because the testosterone is elevated and the FSH LH levels are low. Okay.
Low.
Okay. So sex steroids coming from ovary. Okay. Ovarian tumor. Okay. Very high testosterone is a ovarian source. Normal DHEAS excludes adrenal origin because this is a source is DHEAS source is from adrenal and that is normal. So that is a classic for ovarian tumor. Next.
A patient is suspected to have congenital adrenal hyperplasia. Which of the following is the most appropriate initial screening test? A patient is suspected to have CAH. What is the okay? Serum testosterone, serum DHEAS, serum 17 hydroxyprogesterone, LHFSH ratio, cortisol suppression test. Sir, option B, serum DHEAS level.
Yes, 17 hydroxyprogesterone. Okay. Best screening marker for CAH reflects enzyme block in adrenal steroid pathway. So in every question, don't read the whole table, but you just need to look what is increased. DHEA levels are very high. It is suggestive of adrenal source. Then if is the testosterone very high, that is suggestive of ovary. 17 progesterone high, congenital adrenal hyperplasia. If everything is mild, it is a simple hirsutism. Okay. So that finishes the topic of adrenal cortical hormones. Thank you.